Professor Shamez Ladhani. Shamez is a paediatrician, works at St George's, has been leading sort of the approach to COVID in children, and is going to talk to us about whether we should vaccinate children against COVID. Shamez, thank you.
How do you follow a talk like that? So I know Jeremy Farrar because he was the one actually who was instructing what we needed to do when we were back home during the pandemic. And the influence that he had in making things happen was incredible. We wouldn't have been able to do half the stuff that we wanted to do in terms of public health if it wasn't for the support of seniors like him. So great respect for him, and really made a big difference to what we were doing. But I'm coming in from a different angle. I'm coming literally from the other side of the world. And the first thing you'd learn about giving lectures is know your audience. And you guys did everything so differently to the rest of the world. It's very difficult to know where to start. So just so I get a feel, how many of you think that children should be vaccinated against COVID? Okay. And how many of you think that the COVID vaccine should be part of the infant immunization program routinely? Okay. The UK took a very different approach. Okay. And yeah, cringingly, I wrote to vaccinate or not to vaccinate. But that was a question I was asked. One of the things that I think that gets missed is the disproportionate reaction to children during the pandemic, which initially was understandable, but over time became very difficult to reconcile. So if you look at the data, if you look at the UK timelines, for example, not many people are aware that the first decision to give lockdown instructions or restrictions were actually for children. Everything that the hierarchies knew at the time suggested that if this is anything like influenza, then children will be the main drivers in the cause of death of the population. And for that reason, even in the UK, the first decision that was made by the Prime Minister was to close down schools before anything else, because they didn't want the virus to get into children and be passed on to others. And we closed down schools before we went into national lockdown, which came after that. Understandably, at that time, we had very limited knowledge. But we, in public health, did quite a lot of work. Now, it just happened to be that I was on safari when this thing hit off. So all my colleagues had taken up all the exciting stuff in hospitals and writing guidelines and protocols and everything, and I was on safari. And when I came back, there's actually no work for me. And so I started thinking, what does a pediatrician do for a pandemic that only affects adults, and data coming from China saying children don't even get infected? And so my plan of work was mostly around working around children, because at some point the children would go back to school, and at some point we'll have to understand the transmission dynamics. And, children will be at the heart of it, just like the previous influenza pandemics, and we had to prepare for that. And the first thing that we knew for sure is children are not unicorns. They have to get infected if they're exposed. It must mean that they are not being tested. It must mean that we are not understanding how this virus is moving around. So straight on, right from the beginning, we were able to show that when you look at testing practices, and we were only testing symptomatic people at the time, the number of infections in children was much lower than in adults, suggesting that if children do get infected, it will be mild or asymptomatic, which is why they don't end up in hospital and they weren't getting very sick. And we checked that with all our different databases, and we showed very clearly there was no impact on death like we were seeing in adults. There was very little hospitalization in children. And we were able to say, look, children probably get infected. They don't get a lot of symptoms. They don't get very severe disease. You don't need to be brutal with the restrictions. And those, people like us who were in clinical practice right on the front line straight away, we could see very clearly that we weren't getting hospitalizations in children. And this conversation went on for over 2 years. And we used even our local data, and there's not much of this around, where we went back and looked at all the children with a positive virus test in our own hospital, one big teaching hospital in London, But you could see very clearly, even at that time, that more than half the infections that were being positive had nothing to do with COVID. These children were coming in with attempted suicides and traumas and eating disorders and so on, and they just tested positive for the virus. They were not in hospital for severe COVID. And then there is this another group of children who get a virus-like illness that could be due to any virus, and they just get a manifestation of a viral illness, which could be a febrile convulsion, could be acute exacerbation of asthma. But since there were no other viruses circulating at the time, there was only SARS-CoV-2, and that is what was triggering the reaction in children. And really, it was only about 10% of the kids who actually genuinely had COVID. And most of them actually were immunocompromised, and they were being hospitalized mostly because we were so concerned about their underlying condition and not of the disease itself, that we were treating them way before they even got sick so that they wouldn't end up in ICU. And what was really clear over the course of the time is that the number of true infections, true COVID hospitalizations remained low throughout the pandemic. And in fact, when you had the bigger waves of Delta and Omicron, the contribution of serious COVID disease in children went lower and lower, and we were getting much more incidental findings. So another question that came along was PIMS-TS or MIS-C. There was a lot of concern in the beginning. Clinicians who were working with children at the time will realize that this really kept us up at night because we had no idea what it was. We didn't know what it was going to do. We didn't know how it would behave. It had a lot of similarities to Kawasaki disease and required a lot of treatment with immunoglobulin, steroids, and cytokine inhibitors and so on. And it really kept us busy, and it was tough during the first wave, even during the alpha wave that you'll see over here. What we were able to do is we modeled the number of PIMS-TS cases with each wave of the pandemic, and we could see very clearly that the PIMS-TS wave occurred around 3 weeks after the COVID wave, and that we also saw in real life. So children got COVID, they recovered from the infection, and then they developed a post-infection inflammatory syndrome, which led to PIMS-TS and was causing cardiovascular problems. And we could predict this perfectly for the first wave, and we used that to predict it for the alpha wave back in 2020, December, January. But then we started seeing a disconnect by the Delta wave. There weren't as many PIMS-TS cases that we would have predicted. As you can see, the separating from the blue and the red line. And then by the time we came to the Omicron wave, we could see very clearly that we had a lot of Omicron infections, but PIMS-TS was disappearing. It was probably related to your first infection, and you wouldn't get it with your reinfection. And the other thing that we noticed is the age at which you get PIMS-TS was declining. And now almost certainly it's just become one of the Kawasaki diseases. And I'm certain that there are some kids who are triggered with SARS-CoV-2. We just don't bother looking for it as we used to. Childhood deaths was another problem. There's a lot of stories coming from many parts of the world that children were dying of severe COVID. In the United States, there were big stories about children dying of SARS-CoV-2. We just couldn't see it. Every time we looked for it, it was really, really uncommon. And by the time we came to the Delta wave again, we were seeing a lot of infections, but the deaths hardly went up at all. When Omicron came, it became even more separated. And we did some estimates that suggested that by the time Omicron came, the risk of death was almost between 1 in 500,000 and 1 in a million cases. It was an extremely rare event. The thing that I learned the most actually is how science and politics don't always shake hands. So if you remember correctly, the vaccines in the UK at least started coming in December 2020. And we started vaccinating the older adults and care homes early January 2020. It took a while for those vaccines to filter down to teenagers, but what we were noticing is the vaccines were licensed till 18. And what we said is, look, if you're 16 and 17 and you're doing adulty stuff, or you're in healthcare, for example, at 16 and 17, or social care, then you be treated the same as the young adults and get vaccinated as well. And we were already starting to see the signal of myocarditis. And I've put in the QR codes in this one to take you to the JCVI statements if anyone is interested, because the statement of the JCVI at the time, this was on the 4th of August 2021, was very clear. It said, look, we've looked at all the pros of vaccination, all the cons of vaccination. We have looked at the disease and its severity. And on balance, we do not think it is justified to vaccinate all teenagers on health grounds because the disease is not severe and we don't know enough about the vaccine and its side effects. And those were the wordings. But because of the way it was worded and agreed, there was a sentence that said, the margin of benefit based primarily on a health perspective is considered too small to support advice on a universal program of vaccination of otherwise healthy 12 to 15-year-old children at this time. That's how it was left. And not long after that, the chief medical officers of all the nations came out with their own statement saying, okay, you make recommendations on health, we're going to make recommendations on vaccine, on education, and we're going to offer the vaccine to all teenagers because it will keep them in school and it will not disrupt their education, and that way they'll be able to not lose the benefits of health because they are in education. This was Delta. Literally a couple of months later, Omicron came, and this whole concept of keeping in school and reducing transmission went out of the window. But you can see the conflict that happened over there, and actually, those who wanted the vaccine took the vaccine. More than 50% of them realized the kid probably already had COVID during the previous wave and didn't take the vaccine. And there was never it was never mandatory to take the vaccine. And we got to around 50% of teenagers taking the vaccine. But what was interesting at the time, again, we were trying to make this point right from the beginning, is why are you vaccinating the children? If it was because of their own health, we have shown you that they don't get very sick with this disease. If you think it's to prevent infection, then this vaccine is not good at preventing infection, and therefore it's not going to prevent transmission. So it's not like the flu vaccine where even if you give it to them and they don't benefit but others benefit, it might work. Even that is not true. And we showed that quite clearly right in the beginning. This is an adult study published in the New England Journal where with the Delta wave, we're already seeing waning of immunity, and then with Omicron, it just shot down. You literally had a few weeks of protection against the infection, even though it was still very good against severe disease in adults. And when you looked at teenagers who were given the vaccine, again, we saw exactly the same thing. And actually, we went further and we said, what is the benefit of natural infection in terms of vaccination? Can we understand it better, given that by the time the vaccine became available for teenagers, the vast majority already been infected at the time anyways? And this gives a really nice understanding of what the vaccine did and how it changed over time. So when you look at those who've never had infection, you take teenagers who've not been infected with SARS-CoV-2, and we know that from their antibodies, you find that the Delta strain gave you, the infection itself gave you 50% protection, but when you vaccinated, your protection was almost 100%, and it was sustained with the wild type, with the alpha and the delta. And by Omicron, everybody was infected, so you couldn't. So getting the infection and getting vaccinated gave you a far better protection than not getting infected. But with Omicron, the protection was only 20%. And then, with every time you give a dose, the effectiveness of that dose came down very rapidly. So the most protection you're going to have was between 12 to 15 weeks. It really did not protect you against infection. And you could do that with Delta again, with the first dose of vaccine, with the second dose of vaccine, with the third dose of vaccine, and Omicron was starting to show the same pattern again. And so do you think that, okay, we've made this decision, Omicron came, and we know that it doesn't protect against infection. The children are getting infected, and if they go in school, actually they're passing it on to each other and infecting each other even quicker than they would have otherwise. So vaccine had very little role in it. So did we learn from it? Well, the 5 to 11-year-olds came in, and again, the same conversations were taking place, where on the one hand, the scientific committee was saying, look, it's too late. They've all had Omicron. By the time you vaccinate them after the horse has bolted the stable. But again, the wording was there, we have the vaccine, you have to use it, was the messaging. And what you see is, again, the JCVI, the scientific committee, made a recommendation, and their wording is, this is a non-urgent offer of vaccination. 3% uptake. We had a 3% uptake and probably 10 by the end of it, because it was very clear that all the children had already had COVID. Most parents could see that after COVID, their children didn't get sick, they didn't end up in hospital. And then when you go and tell them, well, you now have to go and get a vaccine again, they're wondering why you're asking them to do that after it's happened. And then probably the smartest thing that came of it is that by the time we got to children under 5 years of age, by then I think everybody realized that we have to be sensible about it. And since December 22, more or less, we only offered the vaccine to those in risk groups, in children of any age. And that's from 6 months. We don't have a program for birth, on the basis that vaccinating in pregnancy will protect them until 6 months of age. What haven't I talked about? Yes. Yes. Dear God, long COVID. It's almost a cultural talk on its own, because it just depends where you are in the world as to what everybody thinks it is and how bad it is. But again, the first papers were quite worrying. This systematic review of adults estimated around 80% of adults had long COVID. 80% don't have long COVID, okay? But we came up with such broad criteria, which were relevant in the beginning of the pandemic, but needed to be improved over time. And we didn't do that. And so we had a pediatric systematic review, and 25%, 1 in 4 children had long COVID. We out there could see that 1 in 4 children didn't have long COVID. And the problem with most of these studies is that they didn't have an adequate control group. And so we spent a lot of time writing, so you can't publish this unless you have a control group. We then actually developed the clock study, which has been going on for 2 years, where we had teenagers who were infected and not infected with test negatives, and we monitored them over 2 years to collect their symptoms, to try and understand exactly what it is that we are trying to define. And the clock study has now got over a dozen papers on trying to understand the symptomatology in children with long COVID. And there's a lot of work being done on that, and it's all been published. But one of the most fascinating things that I found is what was unique about the way we took this study. Oh, the whole thing's come up. Okay. The unique thing about this study was we went and asked them questions every 3 months, right? So if you take a cohort of children who've had COVID, and they have symptoms at 3 months, and they have fatigue, they can't sleep, they can sleep, they wake up in the middle of the night, whatever symptoms they had. And then you go 3 months after that, and you ask them the same symptoms again, and then you can monitor the prevalence. But if you know who each of these children are and you can monitor them individually, what you find is that the children who report the symptoms that initially are not the same symptoms children who have symptoms at 3 months, are not the same children who have symptoms at 6 months. And the ones who had the symptoms at 0 months went down. A new bunch of kids got it at 3 months, they got down, and the new bunch got it at 6 months, and it's just fluctuating teenage symptoms rather than disease. And this is actually the COVID negative group, yeah? And the same symptoms, a little more common, are those who were COVID positive. And you can do that with any symptoms. I've taken shortness of breath and tiredness, but this is a consistent finding that these are fluctuating common symptoms in teenagers that go up and down. And within that is hidden a very small group of children who are genuinely suffering from long COVID, and we can't find them because they're all hidden. Okay? And we know that we have a decent cohort, because if you look at loss of smell, there's virtually no loss of smell reported in the negatives, and there's respectable amount of loss of smell, which got better with time in the COVID positive. So we had a good group of teenagers that we were measuring. It wasn't like they were mixed or hidden in there. And therefore, if you do not know what you are defining, how can you monitor it over time, and how can you make plans about what you're going to do to prevent it or treat it? Doesn't stop people doing systematic reviews of all the other bad papers that have already been published. And clearly, and it's very difficult to understand because they've made their own definition of long COVID. And generally, there is a trend towards an improvement with vaccination before. And if you have long COVID and you get them vaccinated, it may or may not show benefit. It's all in the same direction. But you can imagine that if you're not going to show any effect or you're going to make things worse, it's going to be much harder to publish. If you can show it makes a difference, you're more likely to publish. And the other important thing about these studies is they write about the improvement in symptoms, but they don't write about the group of children where the symptoms got worse. Yeah? So generally, in my head, the rule of thumb is if you vaccinate somebody with long COVID, about half of them will find no difference at all. A quarter will get better. A quarter will get worse. And whether that's anything to do with vaccination is your bet or mine. I have no idea. And even in these studies, the authors say, look, we did all this work, we've given you beautiful charts, but we can't do anything with it because it's too heterogeneous. So what about children? Well, this is one of the interesting studies that I did find, actually, because of this paper. And this is a study looking at this EHR program data where you have to be quite impressed because they looked at children who had a vaccine or did not have a vaccine, and they wanted to know what difference did it make with getting COVID or probable COVID. So if somebody says, I have long COVID, or they have symptoms that the authors thought were consistent with long COVID. After confirmed infections, they had big cohorts of over 100,000 in the different groups. And they put it all in a very pretty chart. And what they showed is that the direct effect of vaccination in children with long COVID is virtually none. It's not statistically significant. So if you have long COVID, it doesn't make a difference at all. But there is an indirect effect on long COVID in that if you can prevent infection, then you are not likely to get COVID, long COVID. That is logical, right? So most of the benefits that you're going to get from vaccination is preventing infection, which is a really good thing if we had a vaccine that prevented infection. So it makes complete sense. If you had a vaccine that stopped you getting chickenpox ever again, then you can't get shingles. It makes sense. But not with this vaccine. This vaccine is just not designed to do that. And therefore, it's really difficult to justify using this vaccine unless you want to give it every 3 months and then hope they don't get in contact with other children at all. And then the other thing that's really, really weird is based on this definition, they're getting a vaccine effectiveness of 50 to 90% against long COVID. There is something wrong with the methodology. Something doesn't feel right. You can't have 90% protection against long COVID when we don't even know what long COVID is. So it's very difficult to understand what to do. So where do we go from here? Well, I can tell you a little bit about the UK. There are still some groups that are very keen on trying to define this ongoing risk of COVID in children. And there's a lot of work being done. But nobody is testing. And the best available data are not the best. They're using administrative database where you essentially record whatever you want to. And if somebody tests positive or somebody had COVID, it would come in as a COVID code. What it means, whether it's because of COVID or contributed to COVID, is very difficult to tease out from this particular database. But there's some really useful things that did come out of it, and I have put it on here because there are some things we do have to think about. The first thing is that what you will see here is among the hospitalizations over 3 years, the vast majority were COVID, some were PIMS-TS, some were contributing, and some were nosocomial. And I don't think anybody would disagree with that. And then they did this really fancy graphs, and what you can see is we've had some really, really big peaks of disease with the Delta and Omicron variants, and the new variants are giving you smaller and smaller peak. The other interesting thing about this graph is this is an age graph, and the red line at the top is infants under 1 year of age. And I think we do need to pay a little bit more attention about these infants because I don't think we understand everything about COVID. What was, again, very unusual is that they didn't seem to find any difference in socioeconomic factors. They almost look the same throughout the year, and we know that's not necessarily true. And the proportion with underlying comorbidities is going down rather than up, which is also odd because generally the ones that we do see who get very sick are the ones who have multiple comorbidities. Does anybody know which is the one comorbidity that with COVID that I would not argue against? There's only one. It's not immunocompromised. No, it's no. Well, yeah. Well, we don't measure obesity, so we're okay. But we don't have obesity as such a big problem. It didn't come out in children. It didn't come out as strong in the UK as it did in America. It's severe neurodisability. That is the one thing. We knew that was such a big risk factor from the beginning, that the moment the vaccine was licensed, the UK was the first country to say to give it to adolescents with neurodisability, even though it's never been tested or licensed for children, because these children will die of severe COVID, and we've always maintained that. And again, what the authors then did is they did a heat map of age and time, and what you'll see is that infants do come in. Now, whether that's because infants are getting tested all the time because they come in with fever and they're getting checked, they get respiratory illnesses, they get checked, whether they're coming with severe COVID, it's difficult to tease out. Personally, we haven't seen a lot of severe COVIDs in infants, but that signal is there. That's probably the only group that we have to watch carefully and deal with in the future. But what was interesting, and this is where we are with COVID, and this is a really nice description, is that we don't see PMSTS anymore. There's probably some hidden within Kawasaki disease. We can't tell the difference anymore. We haven't treated one in the last year. Admission to critical care with PMSTS is very, very, very rare. The only group that might get in there are the severe neurodisability children who end up with any virus, but it could be this. Mortality rates has also gone down substantially, and the age of disease has gone down, as I've told you. The authors were trying to make a point that infants still contribute majorly to COVID hospitalizations, and they don't tend to have underlying comorbidities, and therefore it's healthy children, and they're trying to push for vaccination and so on. In real life, we just don't see it, and we need to try and better understand. We're trying to do a lot of frontline studies to understand who these kids are and how we can help protect them. But again, if you look at deaths in children, they are extremely rare. If the one thing you want to try and prevent, like we do with the older adults and the elders, is we don't want them to be in hospital and we don't want them to die. The deaths in children is extremely low. You can count them in your finger for England, which has a population of 55 million or 15 million children. You literally 0, 2, 4, 6. There are very few deaths. And if you look at these deaths, most of them are occurring again in the first year of life. And what was really interesting about this paper, which we knew within 6 months of the pandemic starting, is nearly all of them have a life-limiting condition. This is no longer even a neurodisability. They have life-limiting conditions. And therefore, you have to ask yourself, if SARS-CoV wasn't the cause, any of the other viruses could also be caused because they are at that part of their life. And therefore, how much value would it be to vaccinate to try and prevent this happening, which is what we would like to do. So to vaccinate or not to vaccinate? It's not straightforward. There is a vaccine, it works, it gives you some protection, and so what if it's 1 in a million? So what I've done is I've put in a few things that I think we need to consider, and I'm going to leave it at that. Oh, it skipped completely. Oh, it's gone. Oh. Let's try it. Let's see if this works. Okay, it was supposed to be 1, 2, 3. Clearly not. There are new variants. Every time we bring a vaccine, the variant has gone through. It's been through the population. You've either been immune or you get sick with it. The vaccine is treating an old strain. How helpful is that? They're not seasonal. When do you vaccinate? Do you vaccinate them every 3 months before the winter? If you want to protect them, you've got to vaccinate them regularly because you don't even know when the next variant is coming. Pregnancy. You can't get pregnant at a certain time of the year, so you have to have a year-round program to give to pregnant women for a vaccine that has so many different strains within 1 year. mRNA technology, probably not the best anymore. It did its job during the pandemic. We could do with better technology. It's limited short-term protection. And even if it does protect against infection, you're just preventing it for 3 months, and then the problem continues in 3 months. Unless you vaccinate again, and then you're pushing it another 3 months, it doesn't solve the problem. Pregnant women are now immune. The UK has now stopped vaccinating pregnant women as well, because there's just no evidence of severe disease in pregnant women because they're so immune from vaccines and infection. And they will provide passive protection from infants and everybody. There's so many studies that have shown that. SARS-CoV-2 does contribute to hospitalizations in children with other common viral illnesses, febrile convulsions, acute exacerbations of asthma, those types of illnesses. And yes, they do contribute, but now there are so many different viruses that the question is, does it really reduce hospitalizations in children, or is you just taking away SARS-CoV for another virus to come in and do the job? And we don't really understand that. And I think we need to now that all these viruses are, we need a better understanding of that. There is a disease burden in infants, and I really am interested to know what's happening, and we're doing a lot of work to try and understand. Is it just a testing thing because we test babies because we're so worried about their infections? Is it genuinely they are actually more likely to present to hospital with the symptoms because parents are worried or because doctors are worried? And are these avoidable? Could we avoid it, through vaccination or any other systems that we have in place? I've told you about the life-limiting conditions. Are they genuinely avoidable? mRNA vaccines are not completely safe. They do have adverse events. We know of myocarditis in adolescents. The risk in younger children appears to be lower or rarer, but the heart is the only organ that keeps us alive. And if you damage even 5% of that heart through scarring or whatever, that's going to hit you when you're 80, 90. Is it worth the risk for an infection such as this? And like everybody, and the other problem is if you keep providing the program for SARS-CoV-2, you are taking away resources from other important interventions. Could be anything. But UK is already struggling with their routine immunization program. They need all hands on deck to try and salvage that. And finally, I don't think anybody would disagree. If we had a life attenuated, we'd give it tomorrow. That's not the problem. And I want to finish, if I may, with just a simple anecdote, because the answer is never so simple. I don't know if you're aware of this particular story. So we know what happened in teenagers, and we saw what happened. And the reason I'm showing this is it's just how science and politics and countries work. So the Qataris, for some reason, had an incredible surveillance system, and they kept publishing in the biggest journal, Lancet New England. It was the Qataris, the Israelis, and the Americans, and the UK snuck a couple in, but these guys were really there before everybody else. And they were really good. They had really good data, and you couldn't fault it in any way. And they did the same studies as everybody else. They had really good access to the Pfizer vaccines, and they were showing the studies saying, look, if you look at the Omicron infections in children, the first graph, if you are not vaccinated, you will get some protection from it, but at the end, the lines are going in the same direction, and it's just a matter of time before it catches up. And then in the bottom graph, what it's showing is that the vaccine effectiveness wanes very quickly. So by the time you come to 4 months, your 95% confidence interval is already crossing zero. So you're not getting more than 3, 4, 5, 6 months of protection. The Americans did the same thing, 5 to 11-year-olds, and they said also the same thing. They said, look, if you're previously infected or uninfected, at the end of the day, when you vaccinate, your vaccine effectiveness goes up, and then it comes down by 20 weeks, 5 months, right? Same data. And so what the Qataris said is, look, we are concluding that our findings suggest the need to reconsider the values and strategies of vaccinating healthy children in the Omicron era with the use of currently available vaccines. The Americans said the rapid decline in protection against Omicron infection that was confirmed by vaccination and previous infection provides support for booster vaccination. So I don't think the answer is simple. I think countries with a lot of money can do whatever they want to, and it's not wrong. Other countries may want to reallocate their resources according to what's available. everything I've shown comes from a big team of work who've worked throughout the pandemic, and I thank you for your attention.
Thank you. Terrific. Beautifully presented. So, John, at the back.
Thank you, Dr. Ladhani, for a very interesting and comprehensive summary of the kids' situation. For someone who was involved in developing a kids' coracle calculator, I think they could have come to this talk rather than us spending 18 months trying to develop it. Two questions as a GP, because I get asked by a lot of my colleagues. There are a lot of older people, disabled people, people with immunocompromised. So you focused on a paediatric population, but from a public health perspective, a lot of those clinicians are asked by parents and others, little Johnny's got a snotty nose, should he go and see grandma? And so in terms of actually transmitting COVID to an older population, where are you going to put COVID amongst the various respiratory infections that we've largely ignored until we've actually had COVID in terms of the ranking, in terms of the advice? And the second one, which is probably a bit more punchy and controversial, is that as vaccine experts, we've always talked about reducing hospitalisation and mortality, and you really highlighted, and a lot of us have commented on it, that we actually need better protection against infection. So again, GPs say to me, someone getting on a plane, going to a conference, going to a funeral, or a large event where there are vulnerable people, they can't. People say, well, I can get a booster, but they can't guarantee the level of protection. So those sort of two common clinical questions are what's happening in this current era. What are you going to say to the GPs in terms of ranking COVID amongst other respiratory viruses? And should we be saying to the vaccine manufacturers, you won't get another one licensed unless you make something that prevents infection?
That's 3 questions, of which 2 are... The first one, I can give you a nice punchy answer, which may or may not be palatable. The best way to protect the older adults, the elderly in the community, is for them to get vaccinated. It is not on the children to be given the right or the responsibility to look after the elder because of the virus. Because you can test for SARS-CoV-2, you can't measure all the other viruses. They may be carrying symptomatically or asymptomatically. So
the dilemma is that those older people, have a similar decline in their level of protection from that vaccine against getting infected.
Even against infection, the protection against severe disease and death remains very high in the older adults. And the bit that I was going to say about palatable was if they have been vaccinated and or infected in the past, and if it is the SARS-CoV-2 variant that's going to tip them over, they were already in a very bad state, because that's not what tends to happen. Now, in the elderly population, if they are vaccinated plus or minus, ideally infected after vaccination, then their protection against severe disease and death remains very, very high, unless they are frail or have other reason for that to happen. And there are many other more lethal viruses that could be transmitted rather than SARS-CoV-2. I think the stage is now past where they were non-immune. I think now that they're immune, it's very difficult to die of COVID, even at that age. And if they do, it's due to frailty rather than... Does that make sense? Because SARS-CoV-2 doesn't have that capacity anymore. If you are vaccinated and infected and die of SARS-CoV-2, it's because you're already in a very bad place, and any virus could have done it. It's a very hard concept to get across. It's not only one virus, there are many viruses. And if you're worried about your child being symptomatic and seeing granny, most children carry a lot of viruses that they don't even have to have symptoms for, which could be lethal. And therefore, either we go back to humanity and be humans, or then we completely isolate everybody from each other. There's no in between.
Yes, please.
Thanks very much. Shamez, with often complex discussions around benefit risk behind the policy recommendations, how practically useful did you find the benefit risk infographics that places like the Winton Centre put out, and who do you think their primary audience was?
Like that?
The Winton Centre in Cambridge that often did the benefit risk around VITT or myocarditis.
I mean, that's not where we go to look at risk, and we produced our own risks and we did our own risk assessments. We didn't rely on secondary sources, so we never actually used that. Our decisions were based on, at the end of the day, the JCVI made common sense approaches.
Sorry, I don't mean the committee, I mean in terms of communicating your recommendations.
We did, it isn't like that. The vast majority of the population, at least in the UK, want to be told you're eligible for vaccination, go get vaccinated. You are not eligible for vaccination, wait your turn. And as long as they have confidence in your decisions, that you're making the right decisions, they will not argue. There's a very tiny minority, I'm saying 10% or less, that wants to question or critique what you said, because they believe that the team that's doing the job knows what they're doing. The problem really happens is when you start making statements like, you know, there is a non-urgent offer for vaccination, or we can't vaccinate you for health reasons, but then they start mistrusting. Now they're saying, what games are they playing? Because the scientists are saying one thing, but genuinely, I still believe that they believe the scientists. And that's a horrible thing to say, but the vaccine uptake for COVID in children never really got enough to make a difference. And it may not be the thing to say. I think it has done a lot of damage to trust. It has done a lot of damage to policymakers, and it has done a lot of damage to service provision, because we took away so much of our routine service to provide this service to children, which it wasn't taken up. Because if you have a 5-year-old, they need very specialist nurses who can give the vaccine, and you have to make it available throughout the country. And then you buy all that vaccine, you put it in the right place, and 3% turn up. You know, it was better to waste the vaccine because it costs us more in the resources.
I agree with you that long COVID is incredibly complex to define and to study in a human population. We've done one cohort study where one of the patients reported their long COVID symptom was being jaded.
Yeah, no, it is, and it completely ruins their life. I agree.
Yeah. So I guess, to me, what this is screaming out for is the need for models and lab-based studies to actually inform the clinical studies, because we now have very good models of long COVID in the lab. And I think we should be really uniting that much more to actually inform targeted clinical studies.
Now it's very difficult, especially now, because we've had so many waves, we've had so many levels of immunity, we've had so many doses of vaccine.
But isn't that what we need to reflect going forward? I mean, we're not looking at going back.
No, I completely agree. But to do studies now, I don't know how you do those studies and what it actually means, because we don't even have a definition. We don't have a biomarker. And the groups that we were studying at are now 2-3 years old.
But we do have a definition. It's not great. And we do have a bunch of really good putative biomarkers from the lab. So why not do a study where we include all of that?
Money is the biggest thing.
Yeah, I mean that.
But no, I agree. But also, I just don't think there is an appetite for it. There genuinely is very little appetite for dealing with COVID right now. And in terms of funding as well. I really, we have kids, teenagers in our clock study who really, their lives are disrupted, and you hear, and you have no idea whether it's COVID. A bunch of them do have chronic fatigue syndrome without a doubt, and they need to be in the same system as all the other viruses. But there are certain things that we certainly don't understand. But like any other virus, influenza gives you long-term symptoms that we don't understand because they're so rare. And so not just long COVID, I think there's a need to better understand the long-term immunological complexities of these infections. And it's not related to this virus, but because they're so rare, it's very difficult to do a proper study that is going to be reliable.
So maybe Australia is the place for this, because we've got an appetite for long COVID. The government is prioritising long COVID research. So maybe that's.
Then I'm surprised that it's not yet done. I mean,
Australians are a bit laid back and slow.
It's usually if there's an appetite and there's funding, there's always somebody to do the work.
We have time for one more question, and Peter, you've got the final word but just while you're getting the microphone, do teenagers grow out of FTS, fluctuating teenage symptoms, or does it continue into adult life?
So,
Because I've got a few adult patients.
boys still acting like teenagers.
Yeah.
No,
Sorry,
I mean,
Peter.
That's a minefield. The question about pregnancy and infants being admitted to hospital. My reflection of the Australian data that we have is that they're mostly young children, particularly in the first 3 months, who are febrile and not feeding well, or they have croup. They're probably the two main. And in Australia, we've never had a positive recommendation for pregnancy vaccination. And it's by far the biggest chunk of paediatric COVID we see. And I guess reflecting on the UK's decision to, having had a program to now stop it, would you be inclined to restart it if you were seeing an increase in the number of admissions, or the children recover so we don't worry about it too much, it's just another febrile admission?
no. So there's two really important things that you brought. The first thing is that the vast majority of pregnant women are now multiply immune through multiple episodes of infection and past vaccination. Giving them vaccine will boost their antibodies, but they should have enough antibodies to pass on if they're going to protect their infants. Second thing is, we're not seeing these very sick children in the hospital with infants. We just don't see it. I mean, I go to work and I look after kids, and it's not very often you get a child there who's going to sit there and, a baby, and they say, oh, this is COVID in a baby. That's just not how it works. And therefore, I don't think that's the answer. I think there's something even deeper that's going on in there that we don't understand. I think we need more data to try and understand this. My feeling is like yours. When a baby comes in with fever, you do all the tests, including a COVID test, and it comes in positive. And usually they are sick with something. Usually they have a fever. So they come in, they have IV antibiotics, but they don't stay long and they go home. And those are the kids that are being hospitalized and they have a positive virus, but actually they probably have something else going on, or they're not sick enough. They're just being brought in because they have a fever. And the data, the hospitalization is also 1 or 2 days, which is totally bizarre because you can't get severe COVID and be in hospital for 1 or 2 days. So I'm sure this is an epidemiological fallacy in terms of what we see. But that is the last group that's left, and I think we shouldn't ignore them yet. I think we need to do a bit of work on them. Well, that's where I come from. We are doing quite a bit of work trying to understand these infants before we say anything. But I don't think vaccinating mums is going to be helpful in a country that is fully immune like the UK. I'm assuming here almost everybody's now infected?
Often the mothers are also sick at the same time, so probably they're not terribly immune.
All right. Shamez, wonderful talk. Thank you.
Thank you very much.